Welcome back everyone. Dr. Naveen here from UPSC MEDICO. In this video, we'll try to learn the topic of mother to child transmission of HIV in greater detail. See, what you need to understand, this transmission from mother to child occurs during antepartum period throughout the pregnancy, are mainly the intrapartum period. The highest risk of transmission is during the intrapartum period at the time of the delivery. It can even occur during the postpartum. That is mainly due to breastfeeding. Mainly due to breastfeeding. So what are we trying to do? Just to prevent this transmission, which is a vertical transmission through the placenta, vertical transmission is happening. And then through the breastfeed or breast milk is also the route of transmission. Now, for antepartum prevention, we are putting mother on highly active antiretroviral therapy to suppress the viral load. During the intrapartum, now if the viral load is high, if the viral load is more than 10,000 copies, cesarean delivery is done to avoid the risk of transmission. Apart from that, we are also not doing any unnecessary interventions, operative interventions at the time of, that is, placing fetal electrodes or amniocentesis, cardiocentesis, etc. should be avoided. During the postpartum, if at all there is a possibility, if at all there is a possibility of giving replacement feeding, which is not possible in India due to multiple factors, but in developed countries, the replacement feeding with formula is advised because breastfeeding is known to transmit. Okay, but this is also based on AFAS criteria. That means AFAS means if there is acceptability in the community, okay, if there is a cultural acceptability, if it is feasible, okay, if it is again affordable, if it is sustainable, and if it is safe, then only do it. Otherwise, you can still go for exclusive breastfeeding. Okay, so the risk will outweigh the benefits, but you can still continue breastfeeding in a country like India. But that should be exclusive, not intermittent or mixed feeding. That should be an exclusive breastfeeding. With this simple chart, what I'm trying to tell is there is risk of transmission, and these are the things that we are doing to prevent it. Apart from that, if there is a HIV positive mother giving birth to a baby, okay, HIV pregnant mother should be kept on highly active antiretroviral therapy irrespective of our viral load, irrespective of our stage of pregnancy, irrespective of our CD4 count. She should be on ART. Apart from that, baby after birth should receive nevirapine prophylaxis for almost 6 weeks. So after 6 weeks, we do HIV DNA test. Okay. If it is negative, it's fine. If it is positive, we'll continue HART, highly active antiretroviral therapy, but we'll do two tests, not single test for confirmation of the diagnosis. We do two tests. Okay. So why are we not doing antibody assay? Antibody assay is not useful in newborns because IgG antibody transfer occurs through the placenta. So until 18 months of age, antibody assay like ELISA has a no role. You have to do PCR, which is expensive. Now, if HIV DNA test is negative at 6 weeks, we have to repeat the test at 6 months, repeat the test at 12 months. Okay, we have to continuously repeat the test to see if there is any reconversion at a later part of life. This is very important. Okay, so exclusive breastfeeding can be continued, replacement feeding can be given, and baby should receive nevirapine prophylaxis. So what is the dose of nevirapine is asking in some of the exams. So the dose of nevirapine that we give is 2 mg per kg per dose. Okay, this is given once daily for 6 weeks, as I said. So this is the dosage of nevirapine. Sometimes instead of nevirapine, there is another drug which can also be given, zidovudine. Zidovudine is preferred in high risk cases. What are high risk cases? The mother is not receiving HART. The mother's viral load is very high. The mother actually acquired infection early during pregnancy or breastfeeding. Okay, so in those cases, you can even use zidovudine, but for exam point of view, nevirapine is most commonly given. Nevirapine is most commonly given. Now, what is the risk of transmission? If all these measures are not followed, the risk can go up to 25%. Very high. If you take blood transfusion, it is somewhere around 0.3%. If you talk about needle stick prick, it is somewhere around 0.03%. But highest risk of transfer, if precautions are not taken, is with mother to child transmission. Mother to child transmission. Now, apart from giving nevirapine, the other prophylaxis the mother should be given, the baby should be given is, plus the baby should also receive cotrimoxazole for 4 to 6 weeks of age. Okay, until you exclude HIV. Okay, now if HIV is positive, this should be continued for almost 5 years. So cotrimoxazole prophylaxis 5 years for HIV positive, 4 to 6 weeks if it is HIV negative. So anyway, we are doing it HIV test at the 6 weeks of time with the help of HIV DNA assay. Okay, so these are the important things about mother to child transmission. So the average is 15 to 45% given in many of the standard textbooks, but overall it is 25% risk. Okay, I think these points are important with related to exam.